So for our first lecture today, it's acid-base disorders. It will be the anion gap metabolic acidosis, and it's presented by Dr. Alan Yu, who is from University of Cambridge Medical School, residency and fellowship at Brigham and Women's. And I started learning from Alan when he was at the Brigham. He is now a professor of medicine at the University of Kansas with a clinical focus in nephrology and a research focus in kidney physiology and PKD. Alan, I'm thrilled to hear your talk this morning.
Thank you so much, Alice. Appreciate that. It's a delight to be here this morning. We have back-to-back lectures on acid-base disorders, starting with metabolic acidosis and moving on to metabolic alkalosis. So without any further ado, I'm going to try and skip through my bio. No disclosures that are relevant to this. So the objectives of the first part of this are to review the diagnostic approach to acid-base disorders. We're going to start with the basics. So I apologize if it starts off very simplistic and then try and delve a little bit deeper. Talk a little bit about whatever updates there are. There are not huge advances in acid-base disorders in recent years, to be honest, but these are important conditions that come up all the time at the bedside. And specifically, this first half will review the causes and management of anion gap metabolic acidosis. So when we first see a patient with an acid-base disorder, or for those of you who are doing boards, if you come across a case in one of your questions, I feel like, and most people agree, that the first step is to look at the arterial pH. This determines the state of the blood and extracellular fluid. If the pH is low, that is acidemia, and if it's high, it's alkalemia. So it can only be one or the other. So this tells you the net effect of all of the acid-base disorders that might be going on at any one time. Once you've done that, then you have to decide what are the underlying acid-base disorders that together conspire to alter the pH in this direction. Here I show you the Henderson-Hasselbalch equation, not because you need to memorize it, you most certainly don't, but because it's quite helpful, certainly for me, to visualize how the serum bicarbonate, which by the way is often, which is measured and often reported as the serum total CO2, so don't be confused, and the actual partial pressure of CO2 in the blood affect the pH. And this is because the equilibrium between bicarbonate, carbonic acid, and CO2 are the determinants of the major buffer of acid in the blood. And so this is the equation. So the pH is basically dependent on the log of the bicarbonate concentration divided by the PCO2. And so you can immediately see that when the bicarbonate goes up, your pH goes up. When it goes down, the reverse. And the opposite occurs when your PCO2 goes up, your pH goes down. And so you can easily reason that in an acidemia, if the bicarbonate is low, it must be caused by a metabolic disturbance that's causing the acidosis. So it's called a metabolic acidosis. If your CO2 is up, that's a respiratory acidosis, and the reverse for a metabolic alkalosis and respiratory alkalosis. And then the third step is to look for both the expected compensatory response, because the body has an excellent ability to compensate for and correct for acid-base disturbances, and by so doing to diagnose mixed disorders. So there are a number of ways of doing this. This is one. There are tables that you can use to look up the expected compensatory response to a primary disorder. So, for example, here we're showing that in a metabolic acidosis, it is expected that as the bicarbonate drops, that you would expect the PCO2 to go down. In other words, you would hyperventilate to try and breathe down the CO2 and correct that acidosis, something that we often call Kussmaul's breathing. And the actual quantitative amount is expected to be about 1 milliequivalent decrease in bicarbonate, causing about a 1.2 millimeters of mercury decrease in PCO2. And in fact, the respiratory response to metabolic acidosis is one of the most reliable. In a metabolic alkalosis, it's the opposite. As the bicarbonate goes up, the PCO2 goes up. This is not as reliable because obviously there are other factors that control our respiratory ventilation to prevent severe hypoventilation, such as hypoxia, for example. When you look at the metabolic response to respiratory disorders, you will see that we list those as acute and chronic, and acute being within 2 to 3 days and chronic being longer than that. And the reason is because the metabolic response, which is usually a change in the renal excretion of bicarbonate, takes several days to fully occur. And so in the initial steps after a respiratory disorder, the bicarbonate barely changes, and in after several days, there's a much larger change, and that's why those are there. A second way to look at these is with a graphic diagram like this one, which is called a Davenport diagram. And then the third way is, of course, to use your favorite pocket device like your phone and look it up on one of those apps, which I think is probably what most of us would do now. So for those of you taking the boards, the important thing is you do not need to memorize any of these equations. And that makes sense because most of us don't memorize these when we're on the bedside. We look it up when we need it. But what you do need to know is you need to remember the direction of the compensation. You need to remember that compensation is almost never complete, meaning that if you have an acidemia and you're attempting to correct the pH to reduce that acidemia, it doesn't correct the pH back to normal, because if it did, then there would be no more driving force for that compensation. And then I personally like to remember one of these, which, as we discussed, the response to metabolic acidosis, the change in the CO2 is fairly reliable. And there's a nice, neat formula called Winter's formula that many of us use, which states that the predicted CO2 in a metabolic acidosis is 1.5 times the bicarbonate plus 8, and this is accurate to within 2 milliequivalents per liter. And I like this because it comes up all the time at the bedside and it's easy to remember. So here are a couple of very simplistic examples. Here you have a patient whose pH is 7.34, so this is an acidemia. We're looking to see whether this is caused by a respiratory acidosis, in which case the PCO2 should be elevated, or a metabolic acidosis, in which case the bicarbonate should be decreased. And here you see the PCO2 is elevated, so it looks like a primary respiratory acidosis, and the bicarbonate, instead of being decreased, is actually increased, which is an expected metabolic compensation for a primary respiratory acidosis. So this would be consistent with a simple primary respiratory acidosis. Here's another example. The pH is elevated to 7.65, an alkalemia. We're looking at the PCO2 to see if it's reduced, a respiratory alkalosis, and indeed it is. So this would be consistent with a primary respiratory alkalosis. We look at the bicarbonate to see if it is elevated to suggest a metabolic alkalosis, and it is also elevated at 35. And now you might be asking, well, which is it? So the answer is it has to be both, because if it were just a respiratory alkalosis, you would expect a metabolic compensation. And if it were just a metabolic alkalosis, you would expect a respiratory compensation. And the fact that you don't see that means that this has to be both disorders at the same time. And that, in fact, explains why this pH is not just a little elevated, but quite markedly elevated, is because this is both a combined metabolic and respiratory alkalosis. So let's let you do a little bit of work. We'll have our first polling question. Which of the following is the most likely cause of the following acid-base disturbance? So this is a pH of 7.4, PCO2 of 22, and the bicarbonate of 14. And your choices are a panic attack, COPD, seizure, salicylate poisoning, or diarrhea. I'll give you a few seconds to respond. Okay, so most of you, all of you have chosen salicylate poisoning, which is what I would agree with. A couple of diarrheas and a little bit of COPD. So salicylate poisoning is the correct answer. I don't have an explanatory slide, so let me just go over this. So here's the key. The pH is 7.40, which is normal. So there are only two possible causes of this. Either there is no acid-base disturbance, obviously not going to be the case in this question, or there are two disorders that are counterbalancing each other. And we look at what those are. The PCO2 is abnormally low, which would normally be suggestive of a respiratory alkalosis. And the bicarbonate is abnormally low, which would be suggestive of a metabolic acidosis. Now, one could be a compensatory response to the other, but if that were the case, that would not return the pH completely to normal. If the pH were acidemic, it would be a metabolic acidosis with respiratory compensation. If it were alkalemic, the opposite way around. But here the pH is perfectly normal, and we conclude from this that there are two disorders at the same time, metabolic acidosis and respiratory alkalosis. So it's not a panic attack because that would cause the respiratory alkalosis, but that doesn't explain the metabolic acidosis. It's not just diarrhea, which would explain the metabolic acidosis, but not the respiratory alkalosis. But salicylate poisoning classically causes both. And that's a common trick question that you see in the boards, by the way. Okay, so now that we've talked about how to assess acid-base disturbances, let's move on to talk about metabolic acidosis. So when we see a patient that has a primary metabolic acidosis, the first thing that I do is to try and look at the serum anion gap to differentiate the different causes. So the serum anion gap, at least in the US, we calculate as the serum sodium concentration minus, excuse me, the sum of the concentrations of the two major anions, which are chloride and bicarbonate. And in most modern labs, the normal range for that is about 8 to 12. Now, why do we do this? This is rather an odd thing to do. So let's go over this. So in our serum and our extracellular fluid, We have anions and cations. Anions are negatively charged, cations are positively charged. So the total concentration of these have to be equal for electroneutrality. We can divide the anions into those that we're measuring in the blood and others that we ignore but are unmeasured. And the same for the cations, and their sums have to be equal. If we now rearrange this equation, you can see that the measured cations minus the measured anions equals the unmeasured anions minus the unmeasured cations. So these are what we're calculating in our anion gap. The predominant measured cation in our blood is sodium. Just for your interest, in Europe, anion gap is often calculated with potassium as well. It's the same thing, but obviously the normal range will be a little bit different. And the measured anions are bicarbonate and chloride. And if you subtract one from the other, you will get all of the other anions in the blood that you haven't measured or accounted for, I guess would be a better way of saying it, minus all of the unmeasured cations. And that's why it's called the anion gap. So what are these unmeasured anions and cations? So here they are listed here. And probably the major unmeasured anion is albumin. We don't normally think of albumin as an anion. It's a protein, but it's a protein that has net negative charge on it, and actually quite a lot of net negative charge. So it's probably the predominant cause of the anion gap. Obviously, phosphate and sulfate, lactate and pyruvate. Under normal conditions, the concentrations of these don't vary very much. And then the unmeasured cations, we don't normally account for potassium, at least in the US, in our anion gap. So it's under the unmeasured cations. And that's because its concentration shouldn't vary that much in normal conditions. Also calcium, magnesium, and most immunoglobulins are net positively charged. So because the albumin accounts so much for the anion gap, we have to correct for it when we're doing our calculations. And usually the correction is for hypoalbuminemia. Never really had to do it for a high serum albumin. But as your albumin falls, the amount of net negative charge on the albumin decreases. So your quote unquote normal anion gap is lower. And the way we usually correct for this is simply to add an amount to the calculated anion gap. And the amount is 2.5 milliequivalents per liter for every 1 gram per deciliter fall in albumin. So if a normal albumin is 4.0, and you have a patient that comes in with an albumin of 2.0, after you've calculated the anion gap, you add a 5 to that anion gap. And that's the anion gap you use to determine whether someone has a high or low anion gap acidosis. So why is it important to calculate the anion gap? The answer is because many exogenous causes of an acidosis generate excessive amounts of unmeasured anions. And so this is a neat way of inferring something even before we directly measure it. So an example that we often give is a lactic acidosis. If you imagine generating a bunch of lactic acid in someone's blood, so what's lactic acid? Lactic acid is the acid portion, the protons, and an anion, which is lactate. When we add this to blood, it gets buffered by the bicarbonate system. And specifically, the hydrogen ions combine with the bicarbonate to form CO2 and water. And by so doing, they combine, so that by so doing, they reduce your bicarbonate concentration in your blood. So here's an example of metabolic acidosis lowering your bicarbonate. And as it does so, it's adding an unmeasured anion to your blood, which is lactate. Excuse me. So your sodium doesn't change. In theory, your chloride doesn't change, but your bicarbonate decreases. So the anion gap, which is the sodium minus the chloride and bicarbonate, is going to go up. And the amount it's going to go up is going to be directly equivalent to the amount of lactate, the unmeasured anion that's added to the blood. So this is a nice indirect way of inferring that there's an unmeasured anion in the blood that you can then go to the lab and ask them to directly measure lactate if you're guessing that's the unmeasured anion. And this is just showing exactly what I mentioned, that if your bicarbonate decreases and your sodium and chloride don't change, your anion gap actually increases. And it's a surrogate indicator of an unmeasured anion. So going on to the causes of an anion gap metabolic acidosis, there are a number of mnemonics that are used to memorize this. Probably the popular one now is called Goldmark. It seems to cover most of the common causes that are currently prevalent, which are G for glycols, meaning mostly ethylene and propylene glycol, O for oxoproline, which is also called pyroglutamic acidosis. L is for L-lactic acidosis, D for D-lactic acidosis, M for methanol, A for aspirin, R for renal failure, and K for ketoacidosis, both diabetic and alcoholic. And we're going to go over very briefly some of these in the remainder of this lecture. But one of the things that you should obviously notice is that most of these are not themselves acids, and it's not obvious either what the anion is in the unmeasured anion. In fact, things like glycols are uncharged alcohols. So how on earth do they cause an anion gap metabolic acidosis? And the answer is that all of these are either themselves metabolized to acids, or they stimulate the endogenous generation of acids. So ethylene glycol is metabolized to a number of acids, but probably the most predominant one is oxalic acid. So the unmeasured anion is oxalate. Propylene glycol is metabolized to lactic acid, so its anion is lactate. 5-oxoproline is itself actually also known as pyroglutamic acid. So pyroglutamate is the unmeasured anion. Methanol metabolized to formic acid, formate anion. Aspirin stimulates mitochondrial generation of cellular and mitochondrial generation of ketoacids and lactic acid. In renal failure, the issue is that in individuals who are eating a normal diet that includes animal proteins, we generate net acid that the kidney gets rid of every day. As your kidney function and your GFR decreases, the ability to excrete those acid metabolites of protein and actually nucleic acid degradation are decreased, and so they accumulate in our blood. And those include sulfuric acid, so sulfate accumulates, phosphoric acid, so phosphate accumulates, which we're all familiar with, uric acid, urate, and a number of other minor ones. So any form of renal failure, acute or chronic, will lead to some accumulation of these acids and their accompanying anions. And then finally, ketoacidosis. Obviously, the acids are the keto acids, acetoacetate and beta hydroxybutyrate, whereas the generation of acetone itself does not cause an acidosis. And then not on the Goldmark mnemonic, but useful to remember also, is toluene abuse or solvent abuse, where the toluene is itself metabolized to hippuric acid and hippurate is the anion. And then the final step, specifically for an anion gap metabolic acidosis that helps with the diagnosis, sometimes at least, is to calculate what's colloquially known as the delta-delta. And that refers to the change or delta in the anion gap divided by the change or delta in the serum bicarbonate, so the ratio of the two. And this really determines whether the increase in anion gap you're seeing, the magnitude of it, is appropriate for the magnitude of the acidosis as determined by how much the bicarbonate decreases. And the principle of the delta-delta is this, that for every 1 milliequivalent per liter of acid added to the circulation, the serum bicarbonate should decrease by 1, and the anion gap should commensurately increase by 1. And so the delta-delta, change in anion gap divided by the change in bicarbonate, should, in theory, be exactly 1 in an anion gap acidosis. Here's how we calculate it. You take your anion gap, subtract it from the mid, I like to use the mid-range of the normal anion gap, which is 10, and then divide it by 24, which is the mid-range of a normal bicarbonate, minus your actual serum bicarbonate. So 1 for that ratio would indicate a simple anion gap acidosis. In theory, if your delta-delta is less than 1, it means that you've got a severe acidosis, but your anion gap is not increased as much as you would expect. And this could occur if there were simultaneously a superimposed non-anion gap acidosis. On the other hand, if your delta-delta is greater than 1, this indicates that you have a quite marked increase in anion gap, but your serum bicarbonate does not seem to have fallen as much as you would expect for a simple anion gap acidosis. And that could occur if there were a superimposed process that were elevating your bicarbonate. In other words, a superimposed metabolic alkalosis. So here's another practice question to get you moving. A 21-year-old male is intoxicated with ethanol and presents with a history of repeated vomiting and is obtunded. And so his sodium's 136, potassium 3.5, chloride of 90, bicarbonate of 18, pH of 7.2, and PCO2 of 45. What is the nature of this acid-base disturbance? And there are a number of kind of complicated choices: mixed anion gap and non-gap metabolic acidosis, anion gap metabolic acidosis with respiratory alkalosis, anion gap metabolic acidosis and respiratory acidosis, or anion gap metabolic acidosis, metabolic alkalosis, and respiratory acidosis. So I think those are the 4 choices. No, there's a 5th choice, sorry, which you see below. And just so you know, these types of questions do come up on the boards. Usually there's one, and you have to go through this quite carefully. So I'll give you a second to work through this. I will say it's not easy, especially when you're in the actual boards and under pressure. It takes a few seconds to do the calculations. And yeah, I think the majority just about got it. I think the optimal answer, there's no one right answer, but the optimal answer, in my opinion, is D. And I'll tell you why. And congratulations to those of you who chose that. So here are the numbers again. And so we can see from this is an acidemia. The bicarbonate is low, so it's obviously a metabolic acidosis. The PCO2 is elevated, which is inappropriate for an acidemia. So there has to also be a superimposed respiratory acidosis. So you already know metabolic acidosis, respiratory acidosis. Of the metabolic acidosis, we're going to calculate the anion gap. It's 136 minus 90 plus 18, which is 108. Oh, that's here. And so that gives you an anion gap of 28. That's abnormally elevated. So this is an anion gap metabolic acidosis. We can calculate the delta delta. The anion gap delta is 28 minus 10, which is 18. The delta bicarbonate is 24 minus the actual bicarbonate of 18, which is 6. And you can see the ratio of the anion gap delta to the bicarb delta, 18 over 6, is 3, which is really very high. And so that would suggest that the anion gap is very high, but the bicarbonate isn't as low as we would expect. And that would occur if there were also a superimposed metabolic alkalosis. So 3 disorders: anion gap metabolic acidosis, respiratory acidosis, and metabolic alkalosis. And that was the answer. Some of you, instead of the delta-delta, may have grown up calculating this a different way, which also works, which is instead of calculating the delta-delta, they calculate just the delta anion gap, which is 18 in this case, and add it to the actual bicarbonate. So in this case, the actual bicarbonate is also 18. So you add it there and you get 36. And what that's really telling you is that if you were to correct the anion gap metabolic acidosis portion of this, what would the bicarbonate end up being? And the bicarbonate would end up being 36, which is elevated. In other words, it's telling you there would also be a metabolic alkalosis. And that's a perfectly legitimate way of calculating it as well, if you find that easier or quicker. I've included in here a few extra slides of things that might be interesting, that are either pitfalls or subtleties. These don't need to necessarily be memorized. They don't come up in the boards, but in practical terms may be somewhat useful. And so there are a couple of pitfalls in interpretation of the delta-delta. One is that the normal delta-delta in an anion gap acidosis isn't necessarily 1. It can be higher than 1. So, for example, we gave the example of a simple lactic acidosis. Well, in a simple lactic acidosis, the delta-delta average is about 1.6 when you measure it empirically. And that's because not all of this acid load is buffered by your serum bicarbonate. Some of it, maybe up to half, is buffered by entering into the cells intracellularly. And so that part of the acid load is not used to lower your serum bicarbonate. And that's why the delta-delta is high. The other flip side of it is in an anion gap acidosis, the delta-delta can be low if those unmeasured anions are excreted rapidly in the urine. And there are a few classic examples. One of them is diabetic ketoacidosis, where the keto anions get excreted. So it's been observed that early in a DKA, when they present, the delta-delta can be high, like with lactic acidosis, maybe as high as 2, and late on it drops into it's as low as 0. So when I think about the delta-delta, I'm a little more liberal in my thinking about the normal range. I would want to see the delta-delta pretty high to be convinced there's a metabolic alkalosis, maybe as high as 2 or more. On the flip side of it, if your delta-delta is less than 1, sure, it could be due to a non-gap metabolic acidosis, but in the differential diagnosis, just consider the possibility that you have a disorder where the unmeasured anion is just being excreted in the urine. And then the final step, particularly for patients who walk in the door or in through the ER with an anion gap acidosis, where you always have to suspect an intoxication, it's really useful to calculate one other calculation that helps to infer about something that might not be directly measured, at least initially. And that's the osmolar gap, which looks for evidence for the presence of unmeasured osmotically active substances in the blood. And here's how we calculate it. So the osmolar gap refers to the gap between what we directly measure, the serum osmolality, by the freezing point depression method, minus the serum osmolality that we can calculate based on the predominant osmoles in the blood, which are sodium and its accompanying anions. So we multiply that by 2. So that accounts for things like chloride and or any anion that's accompanying sodium. Glucose concentration divided by 18. So at least in the US, glucose is commonly measured in milligrams per deciliter. The molecular weight of glucose is 180, so we divide by 18 to convert this to millimoles per liter, because every millimole per liter of glucose contributes a milliosmol per liter of osmolality. And then BUN, blood urea nitrogen, again in the US, measured in milligrams per deciliter, divided by 2.8. And that's because there are 2 nitrogens in urea, each with an atomic weight of 14, so that's 28. So dividing by 2.8 converts this to milliosmoles per liter. It's not something, again, that you need to memorize, but it's actually really useful to know that if you have other unmeasured osmoles in your blood, that if you can measure it, you can actually calculate their contribution to this osmolar gap. And it's simply the concentration, again, in milligrams per deciliter, divided by 1/10 of their molecular weight. The most useful application of this is for ethanol because it's so frequent to see patients come into the ER with an osmolar gap who have alcohol in their system, ethanol specifically, and it's usually very easy and quick to get a quantitative measure of alcohol level. And so once you've done that, you can simply divide that by 4.6 to determine its contribution to the osmolar gap, and that will tell you whether, in addition to ethanol, there are other osmotically active substances that are potentially more toxic that you need to be aware of. And here are some of them. So, next polling question. Referring to the 21-year-old male that we described previously with that triple acid-base disorder who was intoxicated with ethanol, we now have some additional labs which are shown here. And this will take a minute of calculation, so I'll give you a little time. And which of the following statements is correct? There is no osmolar gap. There is an osmolar gap that is due solely to ethanol. There is an osmolar gap that is only partially attributable to ethanol. Ethanol does not contribute to the osmolar gap. The osmolar gap cannot be calculated with the available data. Give you a little second to calculate that. This is perhaps a little bit harder than a board question because you wouldn't necessarily be expected to know how to calculate the contribution of ethanol. But I can assure you at the bedside, this comes up very, very frequently. Okay, and I apologize, we don't have enough time. I know it takes a little while to do these calculations, but the correct answer, I think, is B, and I'll show you why I think that. So here again, calculated serum osmolality. So certainly the answer that said you can't calculate the osmolality is incorrect. We can certainly do that because we have the sodium, we multiply it by 2. We have the glucose, we divide it by 18. We have the urea, we divide it by 2.8. If you can't do 2.8s in your head, divide by 3. If you can't divide 18 in your head, I can't do either. I usually just divide by 20, and it's close enough. But the actual calculation would be 289. The measured osmolality is 318. So the osmolar gap, 318 minus 289 is 29. A normal, quote unquote, normal osmolar gap should be less than 10. There are reasons why it's not 0. These are not exact, shouldn't be exactly equivalent, the measured and calculated, but it should usually be less than 10. So there's definitely an osmolar gap. And then the other part of the question is, how much does ethanol contribute? And remember, we divide its milligrams per deciliter by 4.6 to calculate its contribution. And so the ethanol concentration is 124. So it actually contributes 27 milliosms per liter to the osmolality, which is almost the entire osmolar gap. So this patient really had ethanol as the cause of his osmolar gap and not other additional unmeasured osmoles. Okay, and so it is helpful to memorize all the different intoxications, which ones cause an anion gap acidosis, which ones cause an osmolar gap, and which ones cause both. And here are the most common ones. Salicylate poisoning causes an anion gap acidosis, but there is minimal or no neutral osmotically active substances being generated, and so that does not affect the osmolar gap. These alcohols classically all increase the osmolar gap. So they're all small molecules that can be present in high enough concentration of blood to elevate the osmolality. And each of them is metabolized to either metabolize to an acid or, in case of ethanol, stimulates endogenous ketoacid generation. And so these all cause an anion gap acidosis. And then the outlier is isopropanol, a small alcohol that increases the osmolar gap, but because it's not metabolized to an organic acid, it does not elevate your anion gap acidosis. Okay, so the remainder of this part of the talk, I'm going to talk a little bit about the different specific causes of anion gap acidosis. So let's start with ethylene glycol poisoning. So ethylene glycol is commonly added as a solvent to antifreeze, for example, because it raises the, it lowers the freezing point of solutions. When patients take this, they can appear to be inebriated, just like alcohol poisoning, but you usually can't smell the alcohol. It causes cardiac, respiratory, and renal complications. So it causes heart failure and pulmonary edema, ARDS, and acute tubular necrosis. And it's thought to be because of deposition of both glycolate and oxalate, which we'll get to. Ethylene glycol poisoning is very similar to methanol poisoning, but one of the key differences is it doesn't affect the eye. And so they don't have an effect on vision, and there's no abnormalities if you looked into fundi. As we mentioned, it causes both an anion and an osmolar gap acidosis. Many of these toxins can affect cellular metabolism, and usually the way it does so, as does ethylene glycol, is to cause an elevation in the generation of lactic acid. So your serum lactate may be elevated a little bit. Don't be fooled by this. The way that you determine whether that's the cause of your acidosis is to determine the lactate concentration in millimoles per liter. We're lucky in my lab, it's actually reported in millimoles per liter, but if yours is reported in milligrams per deciliter, you would have to convert it. And you will see that the amount is quite small relative to the anion gap. Because ethylene glycol is metabolized to oxalate, it binds to calcium and causes reduction in ionized calcium, which can manifest as hypocalcemia. These calcium oxalate depositions can also occur in your urine and cause the appearance of calcium oxalate crystals, of which the envelope-shaped dihydrate are the most classic. Here's an example of that. Said to be about 50% sensitive for ethylene glycol poisoning, often accompanied by microscopic hematuria. And because the most common cause of ethylene glycol poisoning is from engine coolant, which I'm told has fluorescein added to it so that car mechanics can see leaks in your car coolant. When you ingest that, the fluorescein causes your urine to fluoresce under a UV light, like a woods lamp that you might find in a dermatology clinic. This is neither sensitive nor specific, but it's kind of cool and a great thing to teach your students on rounds. So the way this works is ethylene glycol is metabolized by alcohol dehydrogenase in our liver, the same enzyme that metabolizes ethanol. And the first metabolite, which is also the most toxic, is glycolic acid, but it's also metabolized to glyxylic acid and oxalic acid. And these are the anion gap acids. Alcohol dehydrogenase is inhibited competitively by ethanol itself, which used to be the treatment to prevent this metabolism, and is still used worldwide. But at least in the US, it's now been supplanted by fameprazole, which is a small molecule drug that is a potent inhibitor of alcohol dehydrogenase. Some of the advantages are it doesn't have to be dosed differently when patients end up on dialysis, if they end up requiring dialysis. And the reason this is important is because these are the toxic metabolites. If you can inhibit the metabolism of ethylene glycol to its toxic metabolites, then you can prevent most, if not all, of the morbidity of ethylene glycol poisoning. The ethylene glycol itself, if you still have good kidney function, will just get excreted in the urine. If you don't have good kidney function, then you would have to get rid of it by dialysis. A little useful tip is to remember that the ethylene glycol is being metabolized to the anion gap acids like glycolic acid and oxalic acid, and the ethylene glycol is what generates the osmolar gap. So if you catch a patient early enough after an ingestion, and this occasionally happens, they'll have a huge osmolar gap, but they may have very little or no anion gap acidosis. Over time, and as you catch them later and later, they may have little or no osmolar gap because all of the ethylene glycol has been metabolized to the acids and the accompanying anions. And so these are worth taking note of when you're trying to interpret osmolar and anion gap and diagnose ethylene glycol, or for that matter, methanol poisoning, which works the same way. The treatment, GI decontamination has very little role in this. Sodium bicarbonate can have some role in trapping these acid anions in the urine, but as I said, the most important and first step is to inhibit the alcohol dehydrogenase and prevent further generation of these toxic metabolites. And that is why being able to interpret the acid-base picture, calculate the anion gap, and calculating the osmolar gap can help you start this immediately in the ER and not wait a long time for the assay for ethylene glycol, which in some hospitals can take a few hours. In others, doesn't come back for several days, and clearly that's unacceptable. And as I mentioned, ethylene glycol is very easily cleared by hemodialysis. Next, we'll move on to methanol poisoning. So this also causes intoxication of the patient. Generally, they do have an alcoholic fetor. This is toxic to the eyes, so it can cause a dilated pupil, retinal and optic disc edema, or even blindness, and this can be permanent. So this is a serious complication. It does, of course, cause an anion and osmolar gap. No detectable ethanol, or there is ethanol, but it's not accounting for all of the osmolar gap. And unlike ethylene glycol, there's no hypocalcemia, hematuria, or crystalluria. But unlike ethylene glycol, for some reason, methanol has a propensity to cause rhabdomyolysis and to cause acute pancreatitis. The treatment is similar, except it's generally recommended to be more aggressive in treatments of acidemia because the formic acid, which is the metabolite of methanol, is more toxic than the anion formate. And if you dialyze patients, it's recommended to avoid heparin because there's also a risk of intracerebral hemorrhage. Moving on to salicylate intoxication. This can cause a huge myriad of different manifestations, particularly in older individuals and in those who are chronically intoxicated, meaning they're already taking aspirin daily and are just taking too high a dose for some reason. In orange, I've tried to highlight some of the manifestations that may be a little more specific and might raise your suspicion that someone's manifestations are due to salicylate intoxication. So they may have nausea, vomiting, and diarrhea, but that's pretty non-specific. But tinnitus and deafness, when you see it, are, again, classic symptoms of salicylate poisoning. They cause an elevation in those three vital signs, temperature, respiration, pulse, are all increased simultaneously. And that should raise your suspicion of a salicylate intoxication, especially if the patient isn't otherwise that sick. But it can cause non-cardiogenic pulmonary edema, seizures, and obviously coma. It can mimic just about any acid-base disturbance, but in adults, the vast majority of patients, like the case that I presented right in the beginning, present with the combination of respiratory alkalosis and metabolic acidosis. And the acidosis is actually due to the salicylate stimulating cellular generation of lactic acid and keto acids. The management of salicylate intoxication is fairly straightforward. Obviously, you want to stabilize patients, but one of the tips here is that you want to try and avoid intubation if you can. And that's because often patients who have appropriate respiratory compensation are already hyperventilating and keeping their pH up. If you intubate them and are unable to keep up with this, then you would actually allow the pH to drop and that actually increases the amount of salicylic acid component as opposed to salicylate in the blood, which can partition into the CSF and actually cause more neurotoxicity. So that's supposedly why you should avoid intubation unless absolutely necessary. Multi-dose charcoal is effective, and for the reasons I just mentioned, it's important to keep the patient's pH elevated. So it's typical to alkalize patients. And this does a second thing, which is to alkalize the urine if you have adequate kidney function, which will trap the salicylate and cause it to be excreted. Importantly, when you're alkalizing urine, you want to use sodium bicarbonate to do so and not a drug like acetazolamide. Acetazolamide will indeed alkalize your urine if you have enough kidney function, but it does so at the expense of acidifying your blood. And as we mentioned, that's what you don't want. And oftentimes they have hypokalemia that needs to be corrected. And again, dialysis is very effective for removing salicylate. Moving on to alcoholic ketoacidosis. This often presents non-specifically with nausea, vomiting, or abdominal pain or abdominal tenderness. Importantly, the glucose will be normal. Most of the keto acids are in the form of beta-hydroxybutyrate, which is what most hospitals use now to detect ketoacidosis. But if your hospital's predominant test is a test of acetone or acetoacetate, don't be fooled if it's negative or borderline. Another thing not to be fooled with is that, fooled by, I should say, is that when you assay the serum for alcohol, there may be no ethanol present. That's extremely common because alcoholic ketoacidosis, as onset, usually occurs after a binge of alcohol as the alcohol is being stopped. Like some of these other toxins, there is usually also an accompanying lactic acidosis, but the important thing is when you calculate the lactic acid concentration in millimoles per liter, it does not account for your anion gap or all of your anion gap, and that's how you know there are keto acids as well. And the treatment, of course, is just dextrose-containing fluids. A rare disorder causing an anion gap acidosis, but one that is difficult to diagnose unless you suspect it, is D-lactic acidosis. Nowadays, a common cause of this is from patients who've had prior bariatric surgery, specifically gastric bypass. The pathogenesis here is that carbohydrates that are normally found in the upper guts become rapidly transited into the colon, where they cause overgrowth of bacteria that generate a form of lactic acid that's not normally in our body. It's generated only by bacteria, and that's the D isomer of lactic acid that is then absorbed into the blood and is neurotoxic. And so this causes episodes of altered mental status. These patients typically come in and out of the ER. When they come in, they are made NPO, and then they recover because this condition can only persist with persistent carbohydrate intake or enteral carbohydrate intake. And so there's spontaneous resolution. Once you suspect this, you can diagnose it by measuring blood or actually urine D-lactic acid. The important thing is if you just send a regular lactate, that measures L-lactate and not D-lactate, and so you would not make the diagnosis unless you send the specific test. Once you make the diagnosis, you can treat the patient in various ways with a low carbohydrate diet or sometimes with poorly absorbable oral antibiotics. Finally, pyroglutamic acidemia is probably the newest condition that's been discovered to cause anion gap acidosis. It's also called 5-oxoproline. It's a condition that occurs predominantly in females, often critically ill or very malnourished, who are treated chronically with acetaminophen and present with an anion gap acidosis. And again, if you don't suspect it, you won't know it because you have to send off a specific test. In our hospital, we send off organic acids in the urine, and it's done by HPLC. Other hospital labs may have different ways of doing this. And the treatment is supportive care, but most importantly, discontinuing the acetaminophen. And I won't go into this in detail, but suffice it to say that this is all part of the pathway that generates glutathione, which is a reducing agent in our body, and it negatively inhibits a key enzyme here. And when glutathione is depleted, which is what acetaminophen does, this negative feedback pathway is lost. We accumulate this metabolite gamma-glutamyl phosphate, and the only place for this to go is to generate pyroglutamic acid or 5-oxoproline. So with that, I'm going to stop this first half, and you can see here some recommended reading material if you would like